My name is Stephanie Forkel, and it's my great pleasure to be here today virtually with you to present our work on the neurovariability and disconnections as new explanatory models for neurology. Now, there's many different ways we can look at the brain, the surface, the subcortical structures, the connections, and the functions. But there's really only two methods we have available to look at the white matter connections in the brain. And the first one is called Klingler postmortem dissection, which is a rather invasive and laborious method to study the white matter. And the second one is based on diffusion-weighted imaging. Now, the advantage of the second method is based on MR imaging, so we can repeat our sampling and we can also collect data from large groups of participants. And obviously it is in vivo, which comes as a big advantage. Now, if we apply these methods to cognitive functions, or rather to map the cognitive functions in the human brain, and we use language as an example, we get a map of the neurobiology of language that looks a bit like this. So you have three cortical areas, one in the frontal, parietal, and temporal lobe, and then you have the arcuate fasciculus that's interconnecting those areas. Now, if we compare that to the maps that we have for the visual and the auditory system in the brain, where each box represents a cortical area and each line a connection between them, then it's probably fair to say that our current model of the neurobiology of language is rather insufficient. Now, tractography and other methods have greatly helped improve our understanding of the anatomy of language. And what you see here is the timeline from the early 19th century, where the arcuate fascicle was described as a frontotemporal connection. Then the early 2000s, Marco Catani discovered the indirect segment that relayed in the inferior parietal lobe. And since then, more recently, we mapped many more white matter connections relevant for language, most of which have already been clinically validated, for example, through neurosurgical approaches, lesion studies, and direct electrical stimulation. Now, one of the problems that we have with the language map that I've just shown you is that it is an average model and it doesn't really fit the individual patient brain. And to illustrate this case, I want to show you the pictures of these women, and some of you may have already recognized them. These are all the 13 women that won the Nobel Prize for Medicine. Now, if you make an average image of what you have to look like to be a female Nobel laureate, we can see that the image in the middle doesn't really look like any of the women around it, nor does it go the other way. No of the women actually look exactly like the template. And that is what we call the averaging problem. Now, this is extremely tangible when we look at faces. It's a lot less obvious when we look at the brain. So what you see here is the average brain, the MNI 152, and we can see that there's areas that are very sharp, like the basal ganglia, for example, and then there's areas that appear blurry on the template, like the temporal lobes, and that is because there's more variability. And just to give you an idea of how variable the brain can be, when we look at the hand knob area in the precentral gyrus, we usually look for an inverted omega sign. But really, this anatomical landmark could be anything between a straight line all the way to an epsilon. Now, looking at the white matter, this variability is even more exaggerated. So if we look at the uncinate here, the hook between the orbitofrontal cortex and the anterior temporal lobe, shown in teal blue here, we can see that our healthy participant on the top barely has the uncinate visible, whereas our healthy participant at the bottom has a really strong connection. Now, these are obviously hand-picked examples, but we did look at the variability in the population for the gray and the white matter. And what we were able to show is that in the healthy population, the variability is not homogeneous across the brain. And that can be seen here by the warm and the cold colors on the surface and the white matter, highlighting high and low variability. Now, there's two important findings here for you to take away. And the first one is that areas of high variability tend to be the ones identified as higher cognitive function areas by neuroimaging and lesion studies. And the second is that for the first time, we were able to show the variability of the white matter, and there is a gradient whereby the deeper parts and the older parts of the brain tend to be more alike between us, so more the same, whereas the more lateral areas tend to be more variable. Now, what this study has demonstrated is that not all the brain is the same, and that focusing on variability in these areas might be a promising avenue of investigation. And coming back to the average problem and the individual patient brain, I just want to give you one example from neurosurgery of a brain tumor patient. You can see the tumor delineated in green here, and we dissected the corticospinal tract in blue. Now, overlaying an atlas onto this particular brain indicated the location of the corticospinal tract as the red area that you can see. Now, what that image shows you is that if you were to trust an atlas, you would completely and entirely miss the corticospinal tract in this particular patient. So this is just a word of caution about using atlases without a personalized approach. Now, the second thing we wanted to look at with this model is, if we are all that variable, does it matter? And we conducted a meta-analysis of 326 studies looking at the structural variability and differences in cognitive functions in healthy controls, neurological, and psychiatric patients. And there's three things that I want to highlight from the study. The first is that we showed that most of what we know about the function of the white matter has been described in brain pathology. So you see that here, 45% of the studies were conducted in neurological and neurosurgical patients, 29% in psychiatric patients, and only 25% in healthy controls. The second thing that we could see is that not all brain connections are studied equally across the cohorts. So looking at the top of the graph, we see that the corticospinal tract, for example, is a very prominent connection in neurology and neurosurgery, but a lot less so in psychiatry and in healthy controls. Now, the third thing was that we could show that variability in anatomy is related to variability in cognitive profiles. And importantly, when the connection is damaged, it causes variable clinical symptoms. And you can see that here exemplified with the arcuate fasciculus, the language pathway, but actually when you look at the literature, it is a prominent connection for language, but it also is recruited for other cognitive functions. And in fact, we see this pattern for every single white matter tract that we were looking at. Now, what this goes to show is that there is no one tract, one function association. Now, let's see what happens when we look at two neurological disorders. The first one is stroke. So in this study, we recruited stroke patients in the acute stage and followed them up longitudinally. And I'm plotting here for you the size of the arcuate fasciculus in the healthy right hemisphere on the x-axis, and on the y-axis, the language recovery 6 months after symptom onset. And highlighting 3 patients here, we can see that patient number 1 didn't really recover language that well, and the arcuate fasciculus in the healthy right hemisphere is rather thin. Our second aphasic patient recovered slightly better, and the arcuate is slightly more prominent. Now, our third patient is, according to the Western Aphasia Battery, completely recovered, and you can see that the arcuate fasciculus in the right hemisphere is really, really prominent. Now, what is interesting about the study is that when we looked at the clinical and the demographic predictors of recovery, we could explain about 30 to 40% of the recovery variance. By adding in the structural variability of the arcuate, we could boost that predictive power to nearly 60%. Looking at an example from neurodegeneration, so here we're looking at patients with primary progressive aphasia, And that is the classical disconnection syndrome, where the inferior frontal gyrus is intact, so articulation is intact. The posterior temporal gyrus is intact, so comprehension, but what is disconnected is the arcuate fasciculus between the two. And that gives rise to repetition deficits. Now, with the emergence of CT imaging, that paradigm actually shifted towards the inferior parietal lobe, where patients with the cortical lesions to the inferior parietal lobe also presented with repetition deficits. Now, we wanted to investigate those two mechanisms and looked at patients with primary progressive aphasia and their reconstruction of the white matter and their cortical morphometry. And what we were able to show is that there's absolutely no correlation with the long segment of the arcuate fasciculus, but indeed we found a correlation with the indirect segments that relay in the inferior parietal lobe. Looking at the cortical areas, the only region that survived multiple comparison correction was the posterior supramarginal gyrus. So what that meant is that after 150 years of conduction aphasia being a disconnection of the arcuate fasciculus, we actually took the arcuate out and proposed a new model whereby lesions along the entire network can cause repetition deficits, but the flavor of the deficit will vary. Now, we've recently looked at all our strokes and in collaboration with many teams across the world and mapped onto the white matter the clinical presentation after stroke. And what this gives you is the first functional white matter of clinical symptoms. And the maps are available in Leah Tolossi's paper in Brain from last year. Now, what's also important about this work is that she developed an online tool that's called the Disconnectome Symptom Discoverer. And what this allows you to do is you can upload a lesion. It will calculate the disconnectome morphospace for an individual lesion. And you can then get a personalized score for this particular patient on their motor function, on their language function, and an array of other 82 cognitive assessments. Now, anyone can use that. It's a software that is running on a website. So if you just go to disconnectomestudio.bcblab.com, and all you need is a lesion mask of your patient, you can upload that, generate the disconnectome maps, and then calculate the score. Now, none of the data will be stored on the website. It's completely compliant with GDPR. Now, the final thing I want to briefly show you is that we recently reviewed the last 10 years of brain connectivity studies and proposed a new model of how the brain works by integrating information from various parts of the brain to give rise to emergent functions. And you can think of this in the context of language as in, if you ask where language is in the brain, it's akin to asking an orchestra where their music is. It's not in the individual instrument, it's not in the individual musician, the notes, or the conductor. It's really in the dynamic integration of all of them at the right time that music emerges. And this is how we believe language works in the brain. Thank you.